I thought it might be useful to talk a little bit about equine porocarcinoma, and I've got some interesting cases to show you. Now, it's difficult to be certain, but many people regard porocarcinoma as the commonest malignant sweat gland tumor that you're likely to encounter, and I think my experience would back that up. This image encapsulates the histology that you would like to see in such a tumor. And right in the center where the cursor is, you can see the most beautiful intracytoplasmic lumen with the nucleus compressed to a little narrow band right at the edge. And then following the lumen, you can see a cuticle going all the way around. And there are similar intracytoplasmic lumina dotted throughout this field. And in addition, you can see nuclear pleomorphism and mitotic activity. Now, it's terribly important that you keep this field in mind because one of the problems with porocarcinoma is that you can mistake a squamous cell carcinoma quite easily for a porocarcinoma, and a squame has a much better prognosis, so it's important you don't make that mistake. Um, so let's just have a think about the gross appearances and what data one can put together about this tumor. It can present at any age, really. The range I've given there is 12 to 91 years, although it does tend to occur in the older age groups and the elderly. And clinically, the commonest site is the lower limb, particularly around the foot. And sometimes the patients will give a history that they've had a lesion there for years and it's suddenly changed, it's got bigger or it's ulcerated. And I can't really think how often I've seen that, but it's certainly something that you may encounter. Now, I suppose I'd put acram porocarcinoma in a sort of a middle of the spectrum between low and high grade. You can see their systemic spread and death occurs between 7 and 11% of cases. Now, to put that into context, squamous carcinoma, if you take all squames occurring anywhere on the body, the mortality is around about 2%. If, on the other hand, you think of squamous carcinoma arising on the lip or the ear, then the mortality goes up to about 10%. But if you were to have a squame on the foot, the mortality would be about 2%. So you can see that there's a significant difference. And again, highlighting why it's important to get the right diagnosis. And I put this little feature in here, malignant hydroacanthoma simplex. And that's essentially porocarcinoma in situ. And it's very, very rare. I used to have a couple of cases, but unfortunately I've long since lost them. But I do have a field to show you later on, which will give you an idea of what that looks like. And here are two more clinical pictures that I found on Google. The one on the left is extraordinary. It's a huge porocarcinoma. And the one on the right, that's fairly typical, presenting as an ulcerated and erythematous nodule. Now, there's not a lot known about the etiology of this tumor. There is some evidence, but not a lot, to say that UVB may be important in some cases. And it's interesting. Merkel cell polyomavirus has been identified in a significant proportion of cases, but it's not thought to be actually involved in the pathogenesis of the tumor. It's regarded as a passenger virus. And I mentioned malignant hydroacanthoma simplex or intraepidermal, but mostly you're going to see an invasive tumor, which by definition shows continuity with the epidermis. And if, for example, you were to compare hidradenocarcinoma with porocarcinoma, the single feature that makes the diagnosis simple is whether it's arising from the epidermis or not. And the tumor is composed of it's a very pleomorphic, but it always looks poroid. And the cells are smaller than you would see in a squamous cell carcinoma, although they do show well-developed intracellular bridges. Mitoses are always present, and sometimes they can be very numerous or even atypical. Necrosis is not something that I think one sees very often in porocarcinoma, but I suppose it may be encountered from time to time, and particularly important is the presence of lymphovascular invasion or perineural infiltration, both of which are indicators of a poorer prognosis. And then the feature which you have to have, if you like, is the presence of intracytoplasmic lumina, as you see on the right, or much less commonly you can come across actual ducts. Now, most porocarcinomas are recognizable at a glance, but there are a lot of variants that from time to time you might encounter. The common ones are clear cell porocarcinoma due to excessive glycogen, and you've got to distinguish that from a clear cell squame. Particularly in dark-skinned patients, you may get pigmented porocarcinoma. And occasionally, at least I've seen maybe 2 or 3 cases that looked extremely boanoid, and I had to search quite hard to find the more obviously poroid features. And even rarer still, you may get a tumor that looks as if it's almost all squamous, but if you look at the deep margin, you can pick up the poroid character. And exceptionally, you may get a metaplastic or sarcomatoid variant, and I'll show you one of these later. And then, very interesting, porocarcinoma is one of those tumors, let's say it's on the foot, when it may metastasize and present with dozens and dozens of metastases on the limbs. And when you look at those histologically, quite often they're totally intraepidermal, and this is called epidermotrophic porocarcinoma. Immunohistochemistry, I think it's useful to look for ducts and lumina with EMA and CEA if you can't see them. And the other immuno I don't think really is desperately important, although if you were thinking about a squame, CK7 would and Burr EP4 would obviously put you into the porocarcinoma rather than the squamous cell carcinoma. And I don't really know whether these are of any importance in the pathogenesis of porocarcinoma, but with the immunohistochemistry, you can show focal or diffuse loss of retinoblastoma and loss or overexpression of P53 and P16. So let's look at a few examples. Now, I mentioned that, or I want to mention, if you like, that porocarcinoma can present in 2 of different ways. And this example is one where the border, the lower border, has a rather pushing quality to it. It's not obviously an invasive, jagged lower border, which is what you tend to see more commonly. In the middle, you see we have the high power, and there's dermal connective tissue that's been compressed by the tumor, which shows abundant intracytoplasmic lumina. And then on the right, there's a very nice, very ugly looking carcinoma cell with a huge nucleus in the middle. And then that's an intracytoplasmic lumen that's been sort of cut at an angle. And if we look in the middle of that tumor, you can see what I mean. The cells are very poroid, they're small, and in this field they're rather uniform, although there are a couple of pleomorphic nuclei just in the mid of the upper central quadrant. But when we look at high power, well, the high power shows you two things. First of all, there are numerous mitotic figures which I've arrowed. Secondly, you can make out nuclear pleomorphism. And thirdly, you can see very nice large eosinophilic nucleoli. I don't think you can see the intracellular bridges very easily on this field, maybe later. Anyway, there's the same tumor showing wonderful intracytoplasmic lumina, and there shouldn't be any difficulty whatsoever in recognizing that this is a porocarcinoma. And there's another close-up view showing that wonderful lumen with the cuticle going all the way around, and then the compressed nucleus at the edge. And this is an example of the more obviously infiltrative porocarcinoma. It's a case that Eduardo Colongi shared with me, and you can see on the low power view on the left, you can see tongues of tumor epithelium growing down into the reticular dermis, and on the top, in the middle field, you can see that there is ulceration of the tumor. And this is a very high power field. It's a little bit fuzzy, but nevertheless you can make out prominent nucleoli, nuclear pleomorphism. And I think in this field you can see quite nicely that there are intracellular bridges joining adjacent tumor cells. And there's a high power of the tumor showing nice lumen formation on the right side, very pleomorphic nuclei towards the top of the field. And here's another view showing marked nuclear pleomorphism. There's an intracytoplasmic lumen. Again, you can make out the cuticle, and you can see the nucleus compressed right to the edge. And there's another view of the same tumor showing very marked nuclear pleomorphism and absolutely huge nucleoli. And there's a mitotic figure, and perhaps that's another one in the upper right field. And then this is a case that Mohammed shared with us on McKee derm, and I thought this was quite nice because it showed you the intra-epidermal component, and if all you had was just that, then this would be a malignant hydroacanthoma simplex, but the tumor obviously is involving the dermis, and on the right you can see nice intracytoplasmic lumina and a little bit of nuclear pleomorphism. And then this is a case, I have to apologize for the quality of this image, but it's a very old old case from my days at St. John's, but it's an example of a bonoid porocarcinoma. And if you look in the middle, you can see the cells are small with rather basophilic cytoplasm and small nuclei. And then elsewhere it looks much more squamous. And I'll show you this in higher power. There's the surface of the tumor, you see, and I think it would be very easy to call that to think of that as being perhaps Bowen's disease. Although you might wonder whether there was some mucin, intracytoplasmic mucin in that lower area there. And there's a high power view of the surface looking very bonoid. But when you get down to the bottom of the tumor, you can see it's much more poromatous. The cells are poroid with huge nuclei in the squamousy bit and much less pleomorphism in the lower bit. And there's a close-up view of the poroid area showing nuclear pleomorphism, prominent nucleoli. Again, we've got these ducts or intracytoplasmic lumina, and that the diagnosis rests entirely on identification of these intracytoplasmic lumina. Without that, you'd end up calling this squamous cell carcinoma. But with their presence, it's clearly porocarcinoma. And then this is a case that Antonina shared with me some couple of years ago, and it's a very nice example. It's a huge tumor, and it's clearly infiltrating down towards or just coming into the edge of subcutaneous fat. And there's the surface of the tumor showing an intraepidermal component, and then epithelial islands extending deeply into the underlying dermis. There's another view showing the medium power of the tumor. And then when we get to a higher power, you can begin to pick up mitotic activity. If you look just where the arrow is, just above the center, you can see two mitotic figures. And there's a close-up view there showing in the center almost a very nice intracytoplasmic lumen. And then on very high power, you can see two mitotic figures, possibly three mitotic figures. There's a nice intracytoplasmic lumen again on the middle of the left-hand side of the field. And then Antonina very kindly marked all of the other mitotic figures. And in this one field, there are 1, 2, 3, 4. There are 5 mitotic figures. And there's another field where there are 3 more mitotic figures. There wasn't a great deal of pleomorphism. There's a mild pleomorphism, but it's certainly not very striking. And I've just noticed that there's another mitotic figure if one looks to the left side in the middle of the field. So that's got 4 mitotic figures. So I think on the basis of mild nuclear pleomorphism, excessive mitotic activity and intracytoplasmic lumina, we can call this porocarcinoma. And there is the EMA staining the tumor very nicely and outlining perhaps this is a small duct in the center of the field. And there's CK5 and 6, P63, and Burr EP4. So this is another case, and again it's a very old case. The histology is not great, but it's an interesting tumor. It's showing a very clear origin from the overlying epidermis, and at this magnification the cells are very basophilic, but towards the surface you can see nuclear pleomorphism, and then as you work your way down it towards the center of the image, you can pick up quite easily that there are intracytoplasmic lumina. And if we look at this a bit more carefully, the top is clearly a carcinoma. In the middle, you can see very marked nuclear pleomorphism, loads of mitotic figures, very nice intracytoplasmic lumina. And on the right field, you can see there's lots of mitotic activity and some apoptosis. But the interesting thing was elsewhere in the tumor, and this is a different part, showing ulceration there and in higher power there, the tumor adopted a spindle cell morphology, which is really quite dramatic and not something that you see very often. But there were very nicely formed intracytoplasmic lumina and quite marked nuclear pleomorphism. So again, despite that spindle cell component, one can determine that this is porocarcinoma quite easily. And then this is a nice case that Dr. Lauren Kiss shared with us. And there are two features that are particularly important in this case. This is the scanning view showing an ulcerated tumor, and you get the impression that it's probably arising from the epidermis, although you can't be absolutely certain. But there's a field there where I think we can pick up an epidermal origin. And the reason I wanted you to see this particularly was because it looks very poroid, but it's the cytoplasm is full of vacuoles, and this is clear cell change due to glycogen, and this is one of those fields that you might confuse with a clear cell squamous carcinoma, and the only real difference is going to be the presence of intracytoplasmic lumina. And there's a high power view there from a different area of the same tumor showing nice lumina and nuclear pleomorphism, prominent nucleolus. So this is obviously another porocarcinoma. But and there's EMA, and here I think we've got a nice true duct formation in addition to intracytoplasmic lumina. And there is CEA picking up some intracytoplasmic lumina just to the left of center. But the other feature I wanted you to see, which is very worrisome, is the extensive lymphovascular invasion. In that field, every vessel is full of tumor, and so this is not likely to behave well. I would put this into the high-grade category, and it would need a re-excision and probably sentinel node biopsy and again investigation to make sure it's not spread further afield. And then this is one case that I saw when I was at St. John's, and unfortunately I've only got these three images left. I used to have a lot more, but this is porocarcinoma showing metaplastic osteoid, and there's continuity with the epidermis. The tumor looks rather poroid, and there's metaplastic chondroid at the top, and there it is in the bottom right. So that's an eccrine porocarcinoma with metaplastic change. I don't really know whether that makes a great deal of difference in a biological sense. I think these are so rare that it's very hard to get a genuine impression of that. And then lastly, differential diagnosis. Well, I think the only real problem that you might have is with squamous cell carcinoma, because sometimes it does contain vacuoles these may be due to glycogen, or they may be an artifact. And I know certainly in the past we looked at an awful lot of squames and we wondered about whether they were porocarcinoma, but we did EMA and CEA and they were completely negative. So if you have any doubts about porocarcinoma versus squamous cell carcinoma, that's the time that EMA and CEA will be a particular help to you. So thank you very much for listening to this talk. I hope it's been of some use to you. And if you have any questions, please ask them in the question part of the video. And once again, thank you.